Hi, and welcome to the Future of Dermatology podcast. I'm your host, Dr. Farah Kamangar, board certified dermatologist. We are here to talk about anything and everything dermatology related. You'll hear from me and my guests who are dermatologists, physicians, experts, scientists, residents, and medical students in the field of dermatology. We publish weekly, so if you like what you hear, hit that subscribe button and show us some love, and thank you for joining us. Hi, welcome back. I am so excited for today's session because it's very topical and something that we all have been struggling with as physicians, dermatologists, but all physicians. Our guest today is Dr. Andrew Weinstein, who is a board certified dermatologist and Mohs surgeon in Florida. He has also served on our AAD, American Academy of Dermatology Board of Directors. He's been a president of the Florida Derm Society, and he is an absolute leader around physician reimbursements and has done so much work around this and given talks on this. So today I'm just so excited to hear about and learn a lot from him. So thank you so much, Dr. Weinstein, for joining us.
Well, thank you so much. It's really great to be here. It's my first podcast.
Yeah, absolutely. It's so great to have you. And I would just love to, you could start anywhere along the journey because you probably have so much history and background into this. Of course, we're speaking on physician reimbursements, which I probably, maybe years ago I might have had to say more, but I think in today's age, I probably don't need to say much. And I think all the physicians understand kind of innately what we're kind of talking about and the crisis we're in, but we might not all really know necessarily the changes that happened that led us here, or what next steps can be taken, or what it kind of means for the future of medicine. So I'd love to just get your thoughts about the entire world of reimbursements and kind of where we are now.
Sure. Let me just start with, I think that most doctors, if we could just go to our offices and treat patients, we would be as happy as could be. But the problem is that we live in an unsustainable environment. So we're the only industry, I think, in the United States that continues to experience dramatic inflation, just like everybody else. But the difference is that we're supposed to see patients and keep our offices open with decreased reimbursement. And I use that term reimbursement very specifically because it refers to just how doctors' offices and departments, every place where medicine is delivered, that's how we get paid back for resources that we've already utilized. So, for example, we open our offices, we pay for the electricity, we pay for the medical assistance, something as simple as the exam table paper, all of the expensive things that we buy, we front the money for that, and then we get reimbursed. And it's interesting, it's in a system that is created and is facilitated by Medicare, but all insurance companies and even some companies that pay for their own medical services use this system, and it's called the physician fee schedule. The physician fee schedule started in 1992. It used to be that doctors would just charge whatever they thought was appropriate for what they did, and that wasn't really something that was sustainable within the Medicare environment. So in 1992, the physician fee schedule was created, and it was designed to make sense of what doctors do. It's based on the resources that we use to deliver service. So we count up everything that I just mentioned. Say somebody comes in for an acne visit, that has been determined, and you count up all the resources and the time of your office and the papers and all the things that you have to do, and you see that patient, and later you're reimbursed for it. So when that was established, it became very clear within 5 years that would continue to grow beyond what the government was prepared to pay for. So they established something called the sustainable growth rate. And it was fine for 5 years. In a few years after the sustainable growth rate came up, Congress said, wait a minute, we're past what we can spend. And so rather than doing something about it, they just said, we'll pay less. And I'll tell you something, we get the proposed rule for next year proposes that we get paid less for the same services than we did in 2001. Wow. And I think we all know that between 2001 and now, we've had dramatic inflation. Forgetting what happened in COVID for a second, it costs something like 50% more to run an office now. You contrast that with how much we get paid. So controlling for inflation, we're down about 29% for that time. So let's contrast that. We're trying to see patients. It costs us 50% more. We get paid 29% less. we're getting to the point where doctors have to do something. And that's why you see so many physicians looking for help, looking to do other things, looking to get away from seeing general dermatology patients, looking to not see Medicare patients. And that's a real tragedy. So we have this system. I heard Greg Murphy, who's a congressman from North Carolina, talk about this. He's a urologist as well. He said, imagine you have a hardware store and you have to sell hammers for $1, but they cost you $2. You're not going to be in business much longer. And I'm afraid that's where we are.
Yeah, absolutely. You said it well. When you kind of break it down to that, it's becoming to the point where, and I practice in Palo Alto, and I know everywhere is hit with this. We're not unique to this, but we're in an area where physicians, because it's expensive to live here, physicians can't practice here anymore. Like, that is kind of crazy, isn't it? That thought that, but it's exactly like you say, it's the $2 hammer that you're selling for $1, except in an area where, maybe it's even double that. It costs double that.
It's crazy. So, the idea for Medicare is a wonderful idea that the government came up with. The problem is that they treat physicians and patients differently than they treat all other industries. So let's contrast us with hospitals. So this year, just 2 days ago, the proposed rule for Medicare came out. And unfortunately, I have to report to you that it includes a 2.9% cut for you. So again, we know that inflation this year, the medical index of inflation, the MEI, is up about 4% this year. And they know that too, and they're proposing a 2.9% cut. But you know who's not getting cut and who is getting an inflation-based adjustment? Hospitals, insurance companies, Medicare Advantage programs. That's because they can't really exist in this environment without an increase, because everybody who works for them, everybody in their environment is requiring raises. It costs more to do business, but here's the problem, that they have a built-in sheet for us. The way that cost, that reimbursement that I mentioned to you gets determined is through something called the conversion factor. So they take all these resources that have been established. We have this committee, and it's all medical specialties, the RUC committee, and they say how many resources. They don't say how much you should be paid for something, but they objectively assess the resources that go into anything, to a procedure, to a medical visit. And then, if it's 5 RVUs, you could compare. Maybe a pediatrician's visit is equivalent to reading an X-ray. Who knows? But RVUs get multiplied by this conversion factor. So what goes into an RVU is real. The problem is the conversion factor is manipulated. They can say that we're going to pay you $40 for the conversion factor or $30. So the conversion factor that they propose for this year is less than 2001. And until they start doing things differently, until we get around something called budget neutrality, there's nothing that can be done. But I can promise you that at the point where doctors' offices reach their margin, at the point where academic departments reach their margin, they'll have to close. Mm-hmm. And this is just an irresponsible way for the federal government. I mean, these are our representatives and senators. They need to fix this because they owe a debt to the seniors who they're insuring. Now, it just so happens that transfers to all insurance companies. So whether it's Blue Cross Blue Shield, Humat, whatever it may be, they all use the Medicare fee schedule. So we have to fix it, or it's like a game of Jenga. You pull out enough pieces and it just falls apart.
Yeah, and it's already starting to, we see it, the remnants, right? The physicians and dermatology specifically are more and more burnt out. And people always say, if dermatology is burnt out, what are the other docs doing? And the reason we kind of look at it, we have to see more patients a day just to keep the lights on. And there's only so much you can do. And we're all, pretty tough people. We've worked hard. The physicians will keep trying to work within the system, which is, I think, what the physicians have been trying to do since probably 2001. They've just said, okay, well, the system is this, the rules are this, and we're rule followers. And that's the other thing. That's probably why a field like us, these things can happen, whereas maybe they can't enforce these things on maybe more of a business-oriented insurance company. But so we follow the rules, we try to adapt. But like you say, there's only a certain amount of pressure that can be applied to any system or any individual. So many physicians are leaving clinical practice, which is a disaster because we're already, especially in dermatology, but other fields too, we're already we don't have enough numbers to see the entire population. The Medicare part just really makes me sad because we love our Medicare patients and we see adults and kids in our practices. So we see our patients that we've been seeing for 8 years, 10 years, and then they turn 65 and then rules change for them. And it's almost at a time where they need the most support and most help, and the system needs to get easier for them. I find them struggling to figure out what plan to get on. There's all these things even within our medical practice that they have to have been seen within 3 years with their primary care, or they might not be able to get back into our entire medical practice, and it's so much harder. And like you said, it's kind of almost like not if the system will fail, it's kind of a when, right? At this point, if you're just constantly, your budget doesn't make sense. You're looking at the EBITDA and all these different things that practices look at. And if businesses close all the time for this kind of reason, but you really can't have the healthcare business close. It's not one that could fail. So yeah, I'd love to kind of hear any, on the other side, are there possible things that can be done? Because sometimes it does, as an individual provider, it does feel like this incredible force that can't be moved or can't be changed.
You're right. I think it's a matter of time. It's not an if, it's a when, because we survive on a margin. That's the difference between what we put out and what we take in. And, sometimes you don't notice it. If your margin's 20%, you don't notice a 1% cut. But once your margin becomes zero, no matter how much you collect, no matter how many patients, you can see 100 extra patients, 0% of zero is zero. And that's where we're heading. And it is a good point that people are just trying to see more and more patients, do more and more with what they have. And that's the cynicism with which Congress sees us. So there's definitely something that can be done. We need to act much more like those industries. So what is it about the insurance industry that resulted in Medicare Advantage getting, I think it's a proposed 3% increase this year? So Medicare Advantage is widely pilloried as being wasteful. I'm not sure how true that is, but if you read analyses by various organizations, there was an article in Medical Economics about this. It's been widely covered in the Congressional Budget Office has talked about this. They've been accused of having excess charges of at least $25 billion. That's with a B, per year. So with that type of press, you would think that they would be on the list just like us, that they would start getting cut. And so leaving aside for a second whether they actually waste that money or not, they have gifted lobbyists. They have a program that really makes Congress stand up and listen. And that's what we have to do. For that matter, the hospitals, the nursing homes, they all have gotten positive inflationary adjustments. So why don't we get raises? It's because we talked about that sustainable growth rate just a few minutes ago, and that was replaced in 2015 with something called MACRA. We should have known this. It's in the law of MACRA. We got 5.5% increases for the first 5 years of MACRA, and then we were scheduled to have zero increases. Now those zero increases become cuts as budget neutrality starts sopping up government dollars. But we should have known that. All of the House of Medicine should have been talking about this 10 years ago, knowing that we're going to hit this 0 point and we weren't going to be able to fix it. The problem is that we're used to fixing it. For those years that we had the SGR, we would go and there would be these doc fixes. Well, that's not happening anymore. The year before that, we got a cut. Last year, we got what ended up being a 2.1% cut, and this year, a 2.9% cut. So what should we do? If you look at how medicine lobbies for its case, first of all, we're always very apologetic. We don't want to go and ask for more money because we don't do this for the money. We do this because we love being doctors. In our case, we love being dermatologists. But we can't do it unless we have appropriate reimbursement. So I looked at the last 10 years of lobbying that we did. I've been to the Hill every year for I don't know how many years with the American Academy of Dermatology, and only a handful of times do we ask for better reimbursement. For reimbursement adjustments. We just don't do a good job. If you look at some societies, when they go to the Hill, they never even mention reimbursement. We do ask for things like clean water, for all things that we should that are undoubtedly important causes, but not the cause of the organizations that are meant to lobby for physicians. So they're there with different messages. Now complicate that by the fact that different specialties are asking for important things. So we might be asking for reform of the iPledge system. The radiologist might be asking for approved mammograms at age 35. All important things, but Congress uses that. It creates chaos. They use it to not give anyone anything. They pick the easiest thing to give and they give it to you. The problem is that we can't afford to do that anymore. So what should we be doing? Well, if you look at the amount of money that medicine spends for lobbying, it's enough. You look at, there are 42 different lobbying organizations and PACs that medical specialties have. The AMA spends a significant amount of money on lobbying, something to the tune of $21 million. The American Academy of Dermatology themselves spend about $2 million. And if you add it all up, it's well over $100 million that the House of Medicine spends on lobbying. But it's all for different messages. They do not have one message. When they go in asking for reimbursement help, they don't ask for something that resonates with Congress. We don't have a way of marshaling our patients, who are the most eloquent spokesmen for us. But most importantly, as messengers, we don't reach out to doctors enough. We don't use the right words to mobilize them and to let them know what an existential threat this is. So we need to stop that. We need to do what everybody else does, and that is hone our message. And so I've been working. I was appointed at the end of Terry Cronin's administration when he was president of the Academy. I was appointed to chair a new task force called the Ad Hoc Task Force, Finding Common Sense Medicare Legislation. And we have come up with a solution, and we started to build an alliance. And the concept is that all of the important medical specialties, and I hope they all join, but we do need a critical mass to join, will join in with this. And all of the messaging to Congress will be the same. It will be produced, it will be message tested, and it will never turn them off. So let me give you an example of what I mean. So if you look at the way the Better Medicare Alliance, who lobbies for Medicare Advantage, talks about it, they don't say we need more money so insurance executives can make more money. They say don't cut Medicare. We need to make sure that our message is unambiguous, but doesn't sound like it's self-serving. We need to have a message that goes to Congress, and we probably need different messages for different sides of the aisle. We need messages for doctors to join our alliance, and then we need a message for the grassroots, for Medicare recipients. Once we have that and we know that it works, that is, it's message tested with focus groups, we can unveil them. The second part of it is we need to join our PACs. There's no question about it. It is an unfortunate reality of American politics that Congress doesn't really want to do something that's going to cost them a lot of energy. So in the context of this, if they were to fix this and they were to give us an inflation-based adjustment, there would be a $30 billion with a B dollar price tag to that. That, of course, that would be a good thing for them to do, but there are so many reasons why they don't want to pick that up. So they're going to kick that can down the road as far as they can. They need some pleasure to go along with the pain of dealing with that. And what's that pleasure? That pleasure is contributions to their reelection campaign. And that's the way things happen. That's the way hospitals, insurance, and nursing homes have been able to get these inflationary adjustments. So what I propose is that all of the PACs, all of the medical specialty PACs continue doing what they're doing, and they decide how important this message is. And they contribute to this single alliance specialty PAC. And then, of course, doctors around the country need to host legislators in their homes. They call that bundling, where the legislator comes, speaks on Medicare, and then receives a contribution. You know, that's a poorly kept secret. That happens in places all over the country. And that is how things change. It's unfortunate, but it's true. And so from my point of view, I was upset about that for a lot of years, and then I ignored it for a lot of years. Yeah. Now I see that the Medicare Advantage program has painted a roadmap for us. And that is, we don't need to give any more money. We just need to give smartly. And that will push this message forward. And you know what it does is it gets rid of this question that congressmen always ask us. They're like, how are you going to pay for it? That's their job to figure out. And with enough motivation, I know they will.
That's incredible.
How cynical does that sound?
That actually was so optimistic. I feel like I'm getting like, yes, let's do this. Let's do this together, because you're really explaining a path. Because I think we feel the heaviness of the problem. And you think, well, how could that ever get fixed? But you're really painting a possible path for it, which is so optimistic. And it's so important for all physicians to hear. The few things that really resonated with me too, all of it really, but you're right. We don't, as physicians, we're not comfortable talking about money. So when it comes to matters of money, we're sort of like, well, others will figure it out and we don't need to really go there. But it's gotten to a point of past okay, we just want more money or self-serving, to the point where our colleagues are so burned out that they are literally our hospital systems are having to give us mental health resources because of not because like our work is hard or our dermatology work is not fulfilling, but because the system is pushing people to see more and all of these kind of things. So it's burning out our colleagues. Our patients could possibly get less good care if you have to just squeeze in more patients and decrease the time that you see them. So it almost, I think now is at a point where I think any physician will agree it's past the point of kind of our discomfort around talking about money, which is probably, I think, one of the main reasons we probably ended up here. I would assume the insurance company, or let's say if we were a group of lawyers, for example, wouldn't have any trouble kind of fighting this even earlier than it did. For the physicians, it's an uncomfortable thing to discuss. So it's gotten to the point of kind of, okay, now it's an emergency that we have to do this. And the other piece that really also resonated with me is my problems are much smaller as a department chair of a group of about 20 docs, but they resonate with the similar methodologies. So a lot of the docs will come to me with different things of different levels, right? So different problems on a list. And then I have to take it up to our admin, and we're within this multi-specialty group, and we're affiliated with kind of a more of a very corporate medicine kind of group. And they have to kind of tell us what we can get and what resources. And it's exactly the same barriers. If you give them too many, there's a little bit of a game to be played with it, and you have to really see what our outcomes are that we need and we want, and how to get there. And you really have to go with just one or two things. Like you said, if you're going with multiple things that need to be fixed, then none of them will get fixed. So you have to go with that very unified message. So I love that you're really just giving us a path to do this. And I also really agree with you. We go to a lot of our society meetings and local meetings, and there's a lot of great things being talked about, but there are so many of them, and they're so vast and they're so diverse. And some of them are kind of the minutia interest of maybe a smaller group and maybe a minority group that might be bringing a problem forward. Like an eye pledge we all hate an eye pledge, but there might be other problems, even like 7 or 8 down the list, that might even affect less people that are kind of being brought up at our society levels. And maybe we should really be addressing the one thing that is kind of killing everyone right now. So I love that messaging and the path that you kind of draw for us. And you personally are taking on a lot of the burden of getting the word out there. But how can the rest of the field, who doesn't know the history as well as you do, or know the path as eloquently as you do, like how can we magnify you and get this message out there on a wider scale?
Well, I hope we can. I love that you've used the word path so many times, because I say this all the time. I'm the focus chairman in charge of this. So whenever we vary from the focus of this single issue alliance, people say, "Oh, we should unionize. We should do that." I said, "Okay, maybe, but we definitely need to do this." I have a friend who's the department chair of radiology at University of Michigan, and he said, it's obvious to me we need a single payer system because of this, and I don't agree with that, but I said, well, if we're going to do that, before we do that, we need to focus on fixing this problem, because it'll be magnified in that. So why do I like the word path? Because I recognize that the destination that we arrive on is a function of the path that we take, not our intentions. In this sense, with regard to reimbursement, we're going in the wrong direction. So it's like the house is north and we're heading south, and you can't fix that. You cannot fix wrong directions. You have to change them. And sometimes when you're heading in the wrong direction, you have to go back over property that you've already passed over. So it is the path that we take that's going to determine whether we're successful, and not our intention. So we all intend to fix this. So I think that what we have to do is we need to tell our colleagues that this exists. We need them to understand that their future is in their own hands, and we all are members of organizations because of something that you said earlier, that we're uncomfortable talking about money. We feel that we're inexpert on reimbursement, whatever it may be. But it does not. This Medicare problem does not affect the professional staffs at these organizations, whether it's the American College of Radiology, whether it's you name the organization. They are going to they were hired to do what they do. So most likely they're not going to want to do this, and they may even reject the idea of disruption like this. Fortunately, we've taken a few steps. We're working with a consultant who I think really, really embraces this and understands this. And I think that our message now is filtering out not just to professional staffs, but to physicians. So to answer your question directly, the more we speak about this, at American Academy of Dermatology functions, at Florida Academy of Dermatology functions, all of those, the more our colleagues know that this exists, the more dermatologists and other specialists begin to understand this and embrace this and speak at their general state meetings. So it can't just be the Florida Academy of Dermatology; it's got to be the entire specialty. In Florida, it's the why am I blanking on our state organization? The Florida. Whatever it is, and all states have organizations that are not just specialty organizations. The Florida Medical Association.
Right.
Forgive me. Anyone listening who's a member of the Florida Medical Association. Right. My good friend who I was an intern with when I was at Jackson University of Miami is the president of the Florida Medical Association. He's not likely to forgive me for this, but anyway, we need to speak at state medical societies, and then of course, we need to make sure that our colleagues in all areas of medicine understand that this is not about the relative value of specialties over the other. We need to float the entire house of medicine up. We need to fix the conversion factor problem. And then when we're done with that, we can eat each other's hearts out about, well, what's more important, a gallbladder or a bypass, and what's more important, a Mohs surgery or a cognitive evaluation. So I think that we're at that point where it doesn't matter who's more important. It doesn't matter what the relative value of the particular specialty or the service that's being provided, because Congress is and Medicare is using the conversion factor to take all the value out of that. So I think we need to beat doors down with this. We need to talk at as many organizations as possible, but most importantly, those physician leaders who are in charge of the specialties need to hear this. Now, I'm hoping, and I'm confident that they will be invited. I'm hoping that we have at least 5, maybe as many as 7 presidents of national organizations at our legislative day. The American Academy of Dermatology holds a legislative day in September where we go to the Hill and we lobby. We're going to be asking for one thing, and that is a inflation-based adjustment to the Medicare fee schedule. And I'm hoping that those other specialty presidents can come in and I can outline this organization that we have. And my hope is that they join and that they become the first members of the board of directors of this alliance to save Medicare, because really it's an alliance to save our patients. Then it becomes self-sustaining. And then I think the success of it receives contributions from the PACs, and we amplify those PACs. So Skin Pack is a $2 million per cycle PAC. That's amazing. We're probably the 3rd or 4th largest PAC. So smaller PACs and larger PACs can amplify this message by giving only, this PAC giving is only related to fixing our fee schedule. And then, of course, once the success of that is illustrated, I'm hoping that our colleagues in homes and offices around the country host like-minded House members and senators who are motivated to save seniors or are motivated to save the Medicare system, because it's a wonderful system. So I think if we do that, we'll have so many champions in Congress that it'll erase the question, how are we going to pay for this? We will have congressmen pushing their colleagues saying we need to find the money just like they do for other causes. There's no shortage of money in Congress. They spend it all the time. They just need to allocate it for this.
And you make a really good point too. It really is not a dermatology specific problem. There's so many things that kind of can divide specialties, but this is not one of them. So it really is probably definitely the most important issue that all specialties are dealing with. So it's amazing that you guys are looking at it that way. Of course, there's the PAC and the AED, but it's a problem of everyone, like all physicians. And it's, how have you been finding that? Is it an easy task to try to unify all the specialties? I know this is work of a lot of the House of Medicine, and AMA does a lot of work around this. Is everybody kind of getting to the point of being on the same place with this, whereas we can disagree on many other topics, but this is definitely one that everyone can unify around?
I wouldn't say it's easy. I would say that I'm very optimistic, though. I don't normally talk to doctors who say, no, you're wrong. The Medicare fee schedule is fine.
Right.
We're doing a great job. But they see the problem as too large. Whenever I talk to somebody who's president of an organization, they talk about the problems that they have as an organization raising money. I think that the biggest thing that we have, the biggest issue that we have, is that this is disruptive. It's in a very good way. It disrupts the way societies do their business. It could be perceived as taking away something that, say you're the person at the American College of Cardiology who's responsible for lobbying. Might you say, well, are they saying I'm not doing a good job? No, of course we're not saying you're not doing a good job. We're saying that the cards are stacked against us and you need help. And we're also saying that this philosophy has never been used before. It's now out of the idea of concept. It's on paper, and we're building an alliance. So I don't think it's easy because it's totally revolutionary. It shouldn't be. I like to say this. It's the most simple idea. It's so hard to do. And so whenever there's change, there's going to be resistance to that change. But if we have such authority on this based on the last 2 years. If everything is going so wonderfully, why are we getting cut? So I say two things to people at the onset. I say, would you prefer a 2.9% cut next year or 4.5% increase in reimbursement? That's the first thing. And then when it's ending, I say, listen, this is an alliance that's happening right now. And if you think that there's a group that's doing anything like this, or is doing well, is doing a good job at what they're doing, you tell me what that group is, and we won't need to do this. And there's not yet been anybody who said, yes, we have the methods. This is what we're planning. People are doing sort of ad hoc messaging. They're making mistakes. They're referring to this as physician payment. This is not physician payment. They are failing to energize their members, and they're using techniques that have proven to fail, and they're ignoring techniques that have proven to be successful. So that's where we are. I am incredibly optimistic that this can happen because the path is there. It's before us. But getting everybody to see this very clear path is not so easy.
Yeah, definitely maybe not easy, but hopefully people are getting there for sure. And you see that unification happening across different disciplines as well. Like, for example, the scientific community, a lot of times the academic centers were in different silos doing their own work. And so much of the scientific community is coming together and sharing knowledge, and labs are working together. So that's coming together. The health data, a lot of the centers are getting their health data on their electronic health records de-identified and sharing with one another to be able to do trials and look for patterns. Even the AI community coming together, sharing thoughts. So this concept of unifying will get us further is happening in a lot of different, I think other groups have kind of led on to that of course together we can kind of do more. So hopefully this is one that people can hop on. And I think it's probably you're probably coming along with this at a time that I think enough pressure has been applied, where I think, like in the beginning, we talked about, we probably don't even need to say too much, and the doctors just innately are feeling that pain right now without knowing where it's come from or what exactly came to be and what the path forward is. They understand the problem in a very deep, visceral way right now. So at least hopefully that alone will be a trigger for most physicians to be able to kind of band together.
Yeah, it's exciting because things aren't kept secret anymore. Like 100 years ago, if you figured something out, I just saw Phil LeBois gave this wonderful lecture where I am now about, he showed this paper from a long time ago, and it was Savat and somebody else. And he said, I think they described a Spitz nevus here. But then it was many years before Spitz described that nevus. And that's how things used to be. When something interesting came up, it might have been in a case report and forgotten for 20 years, and new entities came up all the time that weren't so new. And now we have this potential to cooperate. And I think that that's the beauty of the time that we're in. We can communicate easily. We can communicate directly with each other. And we're reaping the benefits of that in science. And we just need to apply that model here. And I think that's what we're doing.
That's fantastic. And so what are the next steps for, of course, you mentioned, get the societies together, get the society organizers, the AD legislative day. What other things should people be doing, or what messaging do you want to get out there as far as just spreading the word or becoming more active? Like any concrete
I'm
things,
hoping
like
everybody,
top few things we should all kind of do after we've listened to this,
okay,
after we pause the podcast, what should we go into?
The first thing is that the Academy, the American Academy of Dermatology, has spearheaded this. So this exists. This is a sitting ad hoc task force, and you can always get in charge of. You can get in touch with me because I'm the chair of that committee. So I can always help with that. This should be front and center at any meeting. There should be something. Somebody should be talking about this idea of a single issue alliance at every meeting, and once that gains up traction, I think that people should be telling their colleagues, like, why was I talking to my friend who's a radiologist at the University of Michigan? Because I want him to talk about it, and I want him to ask people to join this. And if somebody says, hey, we really should band together, that exists. And if there's a group that's banding together that doesn't quite have it yet, and you hear of that group, they should join this alliance. But that's the next step. Getting our specialties in U.S. medicine to join an alliance together, however they can, is what we need. There is infrastructure for that, and you can get to that through the American Academy of Dermatology. We are working with a consultant called Levitt Partners, which is a Washington consulting lobbying organization, and they're organizing it for us. And as soon as we have this critical mass, we're gonna incorporate it as a 501c4, which is a lobbying organization, and we're gonna start influencing Congress. So I think the short answer to your question is dermatologists should contact me through the American Academy of Dermatology, and I promise I'll use anybody's energy to push this forward. And sort of more in the abstract, we need to tell our colleagues about this. Tell them that there's a single issue alliance, and they should be in touch. If they're leaders in their organizations, they should tell their staff that they want to join this alliance. And if they're not leaders in the organization, they should tell the leaders in the organization that they want, if you're a radiologist, if you're a pulmonary doctor, we want to join this alliance so we can stay in business. So that's the next step.
That's fantastic. No, it's so amazing that all the work that you're doing and offering kind of paths forward for everyone else who's kind of suffering with these things on a daily basis, and just kind of getting the results of, okay, well, this is the new reimbursement rules, and then adjusting their clinics accordingly and figuring out, well, that's this many extra patients this month that I have to see. So you're doing such a hard work at the top level, kind of figuring it all out. And hopefully everybody listening to this too, what would be the best way to kind of contact the task force? Is there email to the task force?
Can I give my email?
If you want people emailing you. Absolutely.
I do. I want you emailing.
I
want you emailing me.
Put it definitely in the show notes below for sure. If you're comfortable getting all the emails, because I think this will probably trigger a lot of conversation. A lot of physicians will want to contact you.
I'm comfortable.
Sounds good.
I'm comfortable with that. So my email address is derm, like dermatologist, at bellsouth.net.
Sounds great. Perfect.
Yeah, and I want to hear from people. So I said this a while ago. I was giving a talk a couple years ago, and I described this, and I said we should do this, and I said, and if dermatology is the only one who sees this, we need to drag the rest of the House of Medicine into this, and that's what we're doing. And so I think it is amazing that it hasn't been thought up before. There are a lot of stumbling blocks, but this is happening. So it's very exciting, and I look forward to hearing from all those dermatologists who want to know how to help and who want to be part of this. And there's another email address that you should know, and that's president@aad.org. Our president, Simal Desai, Dr. Desai, is very supportive of this, but he should hear from you, and he should hear that we want to push this single issue alliance forward. And we want that to be the primary concern. And we want to make sure that we support the idea that we tell other physician organizations at the physician level about this. So email Simal, email me also, and I look forward to working with each and every one of you who bothers to do it.
That's fantastic. And then also at the end, we always ask, since this is the Future of Dermatology podcast, anything you're specifically fascinated by or excited about for the future of dermatology or future of reimbursements?
So there's one thing that I'm excited about with the future of reimbursement, and that is that we'll do the simple thing, and that is add an inflation-based adjustment to the reimbursement schedule, and that'll allow us to keep doing what we're doing. But I never cease to be excited about the innovations in our specialty, the understanding of things, the description of things that didn't exist when I was in medical school, the continued energy of diagnosis and categories and mechanisms of disease, I never cease to be amazed by it. But just like everybody else, I'm excited about what augmented and artificial intelligence is going to enable us to do. So a lot of people are freaked out by it. By some crazy joke, for the last 4 years, I had the privilege of serving on the Augmented Intelligence Committee at the AAD, and it was a bunch of wonderful experts and me. I was ex officio because I was chair of the advisory board, and what a group of talented individuals. We have so much to be excited about, just through the idea. I was listening to a lecture today about melanoma and how melanoma, obviously melanoma is not one disease. And what we're going to need to understand the inputs to that disease state will be made possible by calculations and by information sorting that's made possible by AI. Just the way we use images, the way we're going to be able to improve our diagnosis, our workflow. I'm tremendously excited. While some people are worried about it, I'm tremendously excited about it, and I look forward to everything that is to come. And I'm one of those guys who wants to be practicing dermatology when I'm 85. Because it's just I don't know that I want to do it at the level I'm doing it now, but being able to stay up with these things is just so exciting. And so we're so fortunate to be members of the greatest specialty that's ever been imagined, and we just owe it to the specialty to keep it alive.
Yeah, 100%. I agree with everything you said. AI is special and near and dear to my heart. It's a lot of the work I do as well, and so 100%. The AI is going to be really exciting, and I agree with dermatology is amazing. We love what we do. All we want are the tools and the setup to be able to do this sustainably and to help our patients and treat our patients without having to think about how to keep the lights on at all times. Well, thank you so much. This has been so wonderful. And if you have even any written materials or slides at our society meetings, we'd love to also put those up with any key points. So anything you have, we can add to the show notes on this as well. So thank you again.
Awesome. We are working on that. That's a great idea. I'll make sure that there are things that just can be projected. Wonderful idea. I want to thank you so much for inviting me to this podcast. It's been a ton of fun, first of all. And I'm a subscriber.
Perfect. That sounds great. Yeah, there's a lot of great other episodes. We just actually did one with AI and Mohs surgery too. So you might find that one interesting.
Awesome.
But thank you again.
Love it. All right. Thanks, Farah.
Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below, and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.